Good afternoon, everyone. Today I'd like to share with you a structured, systematic approach to diagnose a case of microcytic anemia. In my presentation, I will focus on three major issues. First, overview of the common cause of microcytic anemia. Next, I will focus on key information on laboratory tests of iron profile. Finally, I will go on to stepwise systematic evidence-based investigation to a patient presenting with microcytic anemia. My talk was particularly relevant to physicians, medical students, and laboratory professionals. Do you know that 27% of world's population are anemic, and more than 50% of whom have iron deficiency anemia? In clinical practice, anemia is classified according to MCV into microcytic, normocytic, and macrocytic anemia. This classification markedly narrows the differential diagnosis that you need to consider for each individual patient. The three major diagnostic possibilities of microcytic anemia are iron deficiency anemia, anemia of chronic disease or chronic inflammation, and thalassemia. Iron deficiency anemia is the most common cause of anemia worldwide. Anemia of chronic disease is the second most common cause of anemia worldwide and the first most common cause in hospitalized patients and among elderly. Thalassemia is common in certain ethnic groups and in certain geographic areas. Before starting a structured approach to patients with microcytic anemia, I will share with you some of the key informations on laboratory tests of iron profile. Serum iron circulates in the plasma. Iron circulates in the plasma bound to plasma protein called transferrin. This is serum iron and this is transferrin. Serum iron saturates about 1/3 of serum transferrin. Serum iron has many limitations. First, it's a labile measure with considerable variation from day to day and hour to hour. It's influenced by recent ingestion or iron supplementations. Since it's essential bacterial nutrient and the tumor cell nutrient, it decreases infection and inflammations. It cannot differentiate between the two most common causes of anemia, which are iron deficiency and the anemia of chronic disease, since it's reduced in both. And also, it's of limited sensitivity. It may be normal in mild anemia. Second test is serum transferrin. It's a plasma protein synthesized by the liver. It's measured in the lab as TIBC or total iron binding capacity. That's to say TIBC is equivalent to transferrin. Its synthesis by the liver is inversely proportional to iron stores and serum iron concentration. In iron deficiency states, transferrin synthesis increase and TIBC level increases in the plasma. In iron overloading states where serum iron and ferritin are high, serum transferrin synthesis decrease and TIBC level in the plasma decrease. A very important piece of knowledge is that serum transferrin is a negative acute phase protein. That's to say, its senses decrease in infection, inflammation, cancer, acute phase response. TIBC increases in iron deficiency anemia. As mentioned before, it's inversely related to body iron status. It decreases in anemia of chronic disease, being acute phase proteins, and it's normal in thalassemia trait. Similar to iron, it's affected by diurnal variation. Really, diagnostically, increased TIBC is specific or characteristic for iron deficiency anemia. However, it has many limitations. It increases in pregnancy, and it decreases infection, inflammation, liver disease, and protein energy malnutrition with elderly aging, because in these conditions, there's decreased the senses of transferrin. And transferrin or TIBC decreases in chronic kidney disease, being lost in urine. Third test is transferrin saturation. It's calculated from serum iron divided by TIBC multiplied by 100%. Its reference interval is 20 to 50. This is serum iron concentration, and this is TIBC. Iron divided by TIBC multiplied by 100% equals transferrin saturation. Transferrin saturation decreases in iron deficiency anemia as iron decreases and TIBC increases, and also it decreases in anemia of chronic disease since both iron and TIBC are reduced. Transferrin saturation percent, therefore, cannot differentiate between iron deficiency anemia and the anemia of chronic disease since it's low or reduced in both. Also, it's affected by diurnal variation like serum iron. Serum ferritin reflects the body iron stores. It's not susceptible to short-term variation that occurs with serum iron levels and TIBC, not influenced by recent iron therapy or ingestion. It's a good marker for iron stores. Low ferritin indicates iron deficiency. High ferritin indicates iron overload. Of all the serum tests for iron deficiency and the microcytic anemia, the serum ferritin is the most useful and definitive test for iron deficiency anemia. And low serum ferritin invariably signifies iron deficiency if scurvy is excluded. That is to say, low serum ferritin can be found in scurvy and in iron deficiency anemia. According to WHO, serum ferritin level is the most specific test correlating with body iron stores, and low serum ferritin indicates depleted body iron stores. In the absence of scurvy or vitamin C deficiency, ferritin cutoff value less than 15 indicates iron deficiency anemia. However, ferritin lacks sensitivity, and about 40% of patients with iron deficiency anemia have serum ferritin above 15. A normal value of ferritin does not reliably exclude the diagnosis of iron deficiency anemia because ferritin is a positive acute phase protein and its levels increase in inflammation and infection. This means that a patient with iron deficiency anemia, if has infection, inflammation, cancer, something like this, serum ferritin will not be less than 15. It will be more than 15. This phenomena complicates the diagnosis of iron deficiency anemia when it coexists with inflammatory disease. That's to say, inflammation can distort the interpretation of serum ferritin, obscuring the diagnosis of iron deficiency anemia. In such a situation, a higher ferritin threshold is recommended for diagnosis of iron deficiency anemia. In 2020, the WHO issued the following publication, WHO guideline on use of ferritin concentrations to assess iron status in individuals and populations. The WHO states that ferritin concentration is a good marker for iron stores and should be used to diagnose iron deficiency in an otherwise apparently healthy individual with a cutoff of 15 in children and in adult and cutoff less than 12 in children. This is in case of apparently healthy individuals. That is to say, apparently healthy individual without cancer, inflammation, or infection. In this individual, a value less than 15 indicates iron deficiency. However, in individuals with infection, inflammation, cancer, acute phase response, a ferritin concentration below 30 and below 70 still indicates iron deficiency anemia. That's to say, ferritin level less than 15 indicates iron deficiency anemia. From 30 to 70, from 15 to 70 in adult having infection and inflammation, it also indicates iron deficiency anemia. Remember that anemia of chronic disease, which occurs with inflammation, infection, cancer, and is associated with acute phase response. In anemia of chronic disease, we find increased serum ferritin, decreased the TIBC because it's negative acute phase protein, and increased ferritin because it's positive acute phase protein. Low serum iron because it's essential nutrient for bacterial and tumor cell, and ultimately to the reduced transferrin saturation. This diagram represents the level of iron profile in different diseases. This is a normal serum iron. This is a normal TIBC. This is a normal transferrin saturation percent of about 1/3, and this is a healthy individuals. Again, a normal iron, normal TIBC, normal saturation, and normal ferritin also occur in thalassemia minor. Thalassemia minor patient has a normal iron profile. This is a patient with iron deficiency. As you see, serum iron is low. This is a normal serum iron. This is a low serum iron. Serum TIBC is high. This is a normal TIBC. This is high TIBC. Saturation is reduced and the ferritin is reduced. This is a patient with anemia of chronic disease. As you see, serum iron is low. This is a normal serum iron. Here is low. Serum TIBC is low. This is a normal TIBC. Saturation is decreased and the ferritin is normal or increased. This is a patient with sideroblastic anemia. There's iron overload. Serum iron is high. TIBC is low. Saturation percent increase and the ferritin is high. Remember that iron profile tests usually change as follows: 3 tests in one direction and 1 test in the opposite direction. In iron overload, ferritin is high, the other 3 tests are low. In iron deficiency anemia, TIBC is high and the other 3 tests are low. In anemia of chronic disease, ferritin is high and the other 3 tests are low. In mixed iron deficiency anemia and the anemia of chronic disease, let's say anemia, iron deficiency anemia with inflammation, serum ferritin, serum iron is low, saturation is low, ferritin is less than 70, and TIBC is normal or low. This is a diagnostic strategy for a patient with microcytic anemia. Once you see an MCV low and hemoglobin level is low, this is a case of microcytic anemia. Request the serum ferritin. This is a standard practice. If the results of serum ferritin is less than 15 or less than 12 in children, less than 15 in adult, and this individual is apparently healthy with no infection, inflammation, cancer, then iron deficiency anemia is diagnosed. However, if this individual has infection, inflammation, or cancer, or acute phase condition, a serum ferritin level less than 70 in adult and less than 30 in child indicates iron deficiency anemia. If serum ferritin level is not consistent with iron deficiency anemia, it's normal or high, request or order other iron profile. If the IBC, iron and transferrin saturation are low. If the IBC is high, this suggests iron deficiency anemia. If the IBC is low, this suggests anemia of chronic disease. If the iron profile is non-conclusive or non-diagnostic like this, then request hemoglobin electrophoresis. If hemoglobin A2 is high, from 3.5 up to 9 or 8, beta thalassemia trait is diagnosed. This is a definitive test for diagnosis of beta thalassemia trait, which is hemoglobin electrophoresis with a hemoglobin A2 value high, with a high hemoglobin A2 value. If hemoglobin E or C are detected, then hemoglobin E or C is diagnosed. If hemoglobin electrophoresis pattern is normal, with normal iron profile, then the most likely diagnosis is alpha thalassemia trait. Alpha thalassemia trait is a diagnosis of exclusion. After excluding iron deficiency anemia, anemia of chronic disease, and the beta thalassemia trait, the likely diagnosis is alpha thalassemia trait. If the electrophoresis is normal with abnormal iron profile, high ferritin, high iron, then likely diagnosed sideroblastic anemia, request order bone marrow aspiration with iron stain. You will find ringed sideroblastic. Again, this is the algorithm mentioned before. This is results consistent with iron deficiency anemia. Here, normal or high ferritin, request the other tests of iron profile, iron, TIBC saturation, TIBC high iron deficiency, TIBC low anemia of chronic disease, non-conclusive iron profile, request hemoglobin electrophoresis, hemoglobin A2 high, beta thalassemia trait, hemoglobin C or E detected, hemoglobin E or C disease or trait is diagnosed. Normal electrophoresis, normal iron profile, alpha thalassemia trait is the likely diagnosis. Normal electrophoresis and abnormal iron profile, sideroblastic anemia. The following are suggestive clues for differential diagnosis of microcytic anemia, although not definitive. In the RBCs, red cell distribution width is a measure of the variation of red cell sizes. It can be used to distinguish thalassemia trait where it's normal from iron deficiency anemia where it's high. Also, it can be used to differentiate anemia of chronic disease where it's normal and iron deficiency anemia where it's high. RDW is a measure of the degree of variation of red cell size. High RDW indicate anisocytosis, which is an early and prominent sign in iron deficiency anemia. Presence of xenophilia could point to parasitic hookworm infestation and could suggest iron deficiency anemia. High platelet count or thrombocytosis commonly accompanies iron deficiency anemia. In iron deficiency anemia, a very interesting finding noted on CBC is the reactive thrombocytosis. Iron deficiency anemia is a common cause of reactive thrombocytosis. RBC count can differentiate thalassemia trait from iron deficiency anemia. In thalassemia, it's high. In iron deficiency anemia, is low. This is a classic picture of thalassemia trait. Normal to high RBC count more than 5 million. No or mild anemia. Low or very low MCV and MCH normal RDW. Menzer index MCV divided by RBCs can help differentiate between iron deficiency, where it's more than 13, and thalassemia trait, where it's less than 13. Thalassemia trait, as you know, MCV is very low, RBC count is very high, so that index is less than 13. MCV value less than 70 suggests iron deficiency anemia, because in anemia of chronic disease, MCV is rarely below 70. In the peripheral blood smear, pencil or cigar-shaped RBCs occurs in suggests iron deficiency anemia. A therapeutic trial, if the diagnosis remains unclear, a therapeutic trial of oral iron therapy could be appropriate. Baseline reticulocyte count is measured. Oral iron therapy is initiated for 7 to 10 days. Then reticulocyte count is repeated. The earliest hematologic evidence of response to treatment is increase in the percentage of reticulocytes, which confirms the diagnosis of iron deficiency anemia. Transferrin saturation percent less than 5 is markedly reduced and indicates iron deficiency anemia. Here, you can see that the degree of anemia, hemoglobin 8, hemoglobin 5, correlates with the severity of microcytosis and correlates with the reduction of RBCs. There's a correlation between degree of microcytosis and severity of anemia. Here, RDW is high. In contrast, in thalassemia trait, you will find marked or moderate microcytosis, as seen here, contrasting the minor degree of anemia or contrasting the no anemia or normal hemoglobin. And RBC count is usually more than 5 million. RDW, as you see in thalassemia trait, is normal. This video is for educational purpose only, and an in-depth review of clinical, laboratory, and radiologic data is indispensable in every individual patient. That's all I have to say about this subject for now, and I think it's time to get our presentation to a close. Thank you so much.